Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Dr. Karen Straube-West. How do you manage patients with skin and soft tissue infections when the guidelines are more than a decade old? How do you navigate the many new options that are now available? That's the topic of our discussion today with two experts in the field. To learn more about this topic, please visit the show notes for this episode. Now let's get started.
Hello, I'm Tom Lodise. I'm a professor at the Albany College of Pharmacy and Health Sciences. I am also the first Blythe Endowed Research Chair of Pharmacy and Pharmaceutical Sciences at the college.
Great, thank you. And my name is George Sakoulas. I'm an infectious disease physician in the San Diego area, chief of infectious diseases at the Rees-Stealy Medical Group. I'm also an adjunct professor at the UCSD School of Medicine and Department of Pediatrics, Center of Inflammation and Host Response. So my background is I'm basically a clinician, ID clinician that does translational research on how antibiotics and the immune system interact. So it's a pleasure to be here, and thank you for having me.
So George, today we'll be discussing the management of patients with skin and soft tissue infections. So before we get into some of the finer details of treating these patients, I anticipate we'll have a little bit of a diverse audience. So if you can just start by briefly reviewing the IDSA skin and soft treatment infection guidelines. They're from 2014. I anticipate some of the members listening to the podcast today may not be familiar with it. And in particular, just kind of the general approach to managing these patients, to some of the key considerations.
Yeah, this is treatment of soft tissue infections clearly is an important thing, and it's unfortunate that it's been 11 years since the IDSA management guidelines have been updated, particularly with newer antibiotics, new considerations in the healthcare environment. The healthcare environment is completely different now, or has changed dramatically today compared to what it was pre-pandemic. I don't think anybody's out there with an 11-year-old smartphone, but yet with an infection that causes 6.5 million office visits a year, 3.5 million ED department visits, and probably close to 1 million hospitalizations. I mean, I think something like this needs to be worked on, not necessarily even for providing better care, but just streamlining it given the burden on the healthcare system. So just a general overview of how the guidelines from 11 years ago are outlined. We usually break them down into sort of two main categories, those with pus and those without pus, or the purulent ones and the non-purulent ones. And then among those subcategories, we then break them down into severity, so mild, moderate, and severe. So the purulent and non-purulent helps us distinguish between staph and strep, generally speaking, with the purulent being Staph aureus, which includes MRSA, and the non-purulent ones being more streptococcal, beta hemolytic streptococci, like group A strep, other Lancefield group FG streps, and the group B strep, particularly in diabetics. And in the mild, moderate, severe, sort of tells us more disposition. Is a patient going to be sent home on an oral agent, admitted to the hospital for IV antibiotics? And I think it's a battleground of the moderates where there's lots of options, particularly with some of the newer agents out there, on how to best manage these in a more streamlined way.
Thank you. So George, do you still believe this is relevant? I mean, do you believe there's any major shifts in the epidemiology of skin and soft tissue infections that we should move away from this general approach?
I think the general approach I think generally stands. I mean, the staph and strep cause the vast majority of these, and people with not a lot of comorbidities. When you add comorbidities, it gets a little bit more complicated, and particularly if they've had prior antibiotic exposure or chronic wounds and so forth. But the purulent, non-purulent designation, I think that's an age-old designation that we had even when I was in medical school, it's actually 30 years ago now. So staph, strep, purulent, non-purulent, I think that goes without saying. I think what can be updated, though, are these disposition categories where we have the mild, moderate, severe. We have agents now that potentially could streamline our moderate cases, which might be borderline for admission. So for cases like that, I think that's where the advancement of guidelines potentially could work to improve upon.
Yeah, and I would agree with that. If you look at the community-acquired pneumonia, going back 20 years, we have the FINE, or the Pneumonia Severity Index, to help guide whether someone should be managed in the hospital or in the outpatient setting, and all based on their predicted 30-day mortality. In contrast, which when we think about skin and soft tissue infections, and as you already identified, there's a higher incidence, we're kind of lacking that. And I know some people go to the Iran classification, but is there any algorithms that you use to help decide whether to manage inpatient or outpatient, or is it more of a kind of a case-by-case basis?
Yeah, I think the Iran classification is sort of a good one. I think that still applies. That's basically where you balance illness severity and comorbidity. And metaphorically speaking, the way I describe this to patients, I describe it sort of like, treating an infection is like stopping a car on a road, right? So how sick you are, how severe the infection is a function of how fast the car is going. And the comorbidities dictate the angle and the surface of the road. Is there ice on the road? Is it downhill on those kinds of things? But just metaphorically, just in a very simplistic standpoint, the Iran classification captures that severity and comorbidities. Are the comorbidities controlled? For example, you can say diabetes generally speaking, but is a diabetic hemoglobin A1C 6 to 7? Or we're talking about a hemoglobin A1C of 14, 15, 16, where the patient can functionally be considered functionally neutropenic. So controlled comorbidities obviously are going to push one towards admission. When they're uncontrolled, when they're controlled, possibly oral, outpatient. So I think it is case by case, but you're using these kind of assessments and these sort of measures on that individual case that you're seeing, because also there's other factors, right? Can the patient be admitted to the hospital? Are they able to stay in the hospital? Do they have family obligations? Do they have a job? They're going to lose their job if they spend 3 days in the hospital. There are other things that go into the mix of deciding whether a patient goes home or comes into the hospital that is individualized. But from a general scheme, the severity of illness and the comorbidity index, I think, are a nice way to frame it.
Yeah. So George, patients sitting right in front of you. And, we'll talk a little bit about some of the starting patients on oral from up front or transitioning them. But someone presents, they call you and they want to get your opinion. Just imagine this is someone who presents to the emergency department and they just wanted to get a second opinion on whether or not this patient should be admitted, or can they be, maybe observation for a short period of time or even discharged home immediately on an oral therapy. So like, what are some of the key factors that influence antibiotic selection for your patients for skin and soft tissues, and in particular, those with acute bacterial skin and skin structure infections, where we're talking more about like cellulitis, abscesses, or even certain types of wound infections?
Yeah, so the first thing you want to, when someone calls you to offer advice on some of these, you want to know how sick the patient is, right? Do they have a fever? Are they have a fever 104? Are they tachycardic in the triple digits? If you have blood work, do they have a leukocytosis or leukopenia? Sometimes with some of these leukocytin-producing Staph aureus infections, you can actually see leukopenia when it becomes systemic. So abnormal vital signs, abnormal labs like white count, someone like that is going to prompt me to say, okay, this patient's probably going to come into the hospital with or without comorbidities. Then you start throwing in the issue of how bad does the area look relative to relative amount of pain, right? So if someone has their leg hurts, but it doesn't look so bad, but they're having excruciating pain and it looks looking to look kind of mottled, then you're thinking about necrotizing fasciitis. Well, then, yeah, that patient, you're not only bringing it to the hospital, but you're actually sending it to the ICU frequently because there's accompanying vital signs abnormalities. Then you might have someone who's less sick, someone who's, let's say, their white count's 11, they got a temperature of 100, their other vital signs are pretty normal, but their A1C is like 12. And you say to yourself, boy, not only is this patient functionally neutropenic, but you no longer have just the staph and strep as a specter of pathogens. So then you have to start worrying about gram negatives, and you have to start asking detailed questions about where they've been around water sources and pseudomonas and those kinds of things. So as you have more unstable comorbidities, even if they're not that sick, you're going to maybe want to bring them in at least to watch them a day or two, observe on therapy, and then before sending them out. Then of course you have the patient who's fairly stable, either stable comorbidities, fairly healthy, and they come in because they cut themselves and now it's rip-roaringly red, but they don't have any systemic symptoms. That patient, you might say, okay, we'll send you home on an oral agent, depending on whether it's purulent or non-purulent. The final factor is, I think, is also the chronicity of the infection. If someone comes in, well, I've had this wound, it's been sitting there for how long? And they tried me on cephalexin, and then I got tried on doxy, and then I tried on this, and the inflammation doesn't seem to be responding. Then you say, again, you have to start worrying more about gram negatives and more resistant infections, particularly Pseudomonas. And if you happen to be practicing in a situation, in an environment where a lot of your Pseudomonases are quinolone resistant, where you really don't have other options, that patient, even though they're not acutely sick, you may have to bring them into the hospital at least to get some cultures and identify what the pathogen is. So I know that's a busy statement, but kind of summarize it that we can dissect going forward.
All right, so George, let me ask you this, and this is the question we always get. Stable comorbidities, everything is the patient may have diabetes or hypertension. Nothing is, I would say, suggesting that an admission require, and their leg is red, but their only real systemic symptom is fever. Do you believe that alone is enough to admit somebody?
Fever alone, no, I don't think so. I mean, as long as your other vital signs are pretty stable. I mean, if they got a fever, low grade fever, and they're otherwise stable, they haven't. You'd also look at how long they've been sick. If it looks like something that started like last night or the last 24 hours, and it looks like it's spread pretty quickly, I would worry less. But someone like this, a non-purulent cellulitis, I think it's reasonable to send them out on if there's not purulent. I don't know, you could do like, I actually personally like clindamycin in this setting. I know a lot of my colleagues cringe a little bit because of the C. diff risk. I think, it is out there, but I'm fortunate in my neck of the woods that probably 80 to 90% of our Staph aureuses are clindamycin susceptible. So even though I'm typically worried about streptococci, I would feel, which Clinda would be appropriate for. Even for Staphylococci, Clinda would not be a bad idea. You could do cephalexin. If you have a component of purulent infection and something is coming, a phlegmon is forming, an area of induration that might form and turn into an abscess, then you might be thinking more about, oh, this is going to be staphylococcal. Then you're going to move away from the cephalexin. Still keep Clinda in the consideration. Again, if you happen to be practicing a situation where I am at, where the majority are clindamycin susceptible, you might do that. But then I might tip myself over something to like minocycline or doxycycline as an agent of choice instead of the cephalexin, because I am more worried about the MRSA, MSSA, particularly MRSA situation here. If you're fortunate, again, we also now have linezolid, which is generic. And if the patient happens to be the population that is not on an SSRI where you're worried about drug-drug interactions, like the very rare but frequently worried about serotonin syndrome, I think linezolid would be a totally reasonable choice, given that it is now more widely available than it wasn't a few years ago, and a minute for most patients without a considerable copay. So those are the doxycycline, clindamycin, cephalexin, linezolid are kind of the things I'm thinking about in the category of patient you just described.
All right, so George, I'm going to ask you for your first line agent and just a couple assumptions. No drug allergies. Let's just start with non-purulent. You've already ruled out any sort of necrotizing process. For someone who you feel you can manage in the outpatient setting, what is your preferred agent?
For non-purulent cellulitis?
Yes.
Yeah, I'd probably start out with cephalexin or clindamycin would be sort of depending on, it's interesting because those two, then you start getting into the sort of mechanism of disease state, right? We always, as ID physicians, we always really like beta-lactam drugs when there's a high inoculum involved. But when you have a toxin-driven disease like this, where it's not the number of organisms that's causing the problem, more the inflammatory response to a small number of organisms, then sometimes a toxin inhibiting / anti-inflammatory agents like clindamycin, the tetracyclines, become potentially advantageous. There actually is some literature out there that shows that relapse rates and outcomes may be better for patients with clindamycin. I think it's in the pediatric literature. But so for me, it's sort of my desire is always to use the beta-lactam if I can, and clindamycin has this specter of C. diff. But those two to me kind of come together as sort of equivalent choices when I look at patients in a non-purulent cellulitis where I'm thinking about streptococci.
So I guess the thing that immediately comes to mind is we use a lot of clindamycin too. but always concerns about a lot of them are macrolide resistant, and there's the potential for inducible resistance among the streptococci. So are these concerns for you as well, using them empirically? Because if you do send these patients home, you're often not going to, if you ever identify a pathogen, if we're not in the business of doing puncture biopsies in these patients,
Right.
but any reservations, does that ever come across your mind that, is this a concern?
It does when there are a lot of bugs there. When there's like, if you have an abscess with staph, yeah, I do worry because then the induction of resistance that you're talking about is a lot of it is inoculum dependent. But if you're talking about a non-purulent cellulitis that's streptococcal, the number of bugs causing a disease is very, very small. So inducing resistance in a small subpopulation is unlikely. So I don't worry about it as much, in a low inoculum infection like this. We know there's very few bugs causing this because people have tried leading aspirate cultures, right? They try to, they've done studies in the old days where they've, instilled saline on the leading edge and aspirated back. And the culture yield is like 10%, if that, because there's just not a lot of bugs there. So when you're worried about a situation that's toxin driven and not inoculum driven, I don't worry about as much about those concerns about induction as we might worry about, let's say, in a staphylococcal abscess, where you have someone with a large abscess or maybe it's a plague bomb that hasn't turned into an abscess yet, but it's heading that way. Yeah, in that setting, I would have the reservations that you just described about induction of resistance and relapse and failure and things like that.
How about we've been using more doxycycline in our practice in recent years, and we've been hesitant to use them for the non-purulent because, again, surveillance data is a bit old. The one thing I would say is resistance rates and the streps have been pretty consistent. And you do see, I mean, if you look at some of the Century data in these other programs, you do see high rates of tetracycline and doxycycline resistance. I mean, do you, and to say someone for whatever reason, they have a history of C. diff or they have a penicillin allergy, would you use doxy or would you consider something else because of the concerns with doxy resistance and the streptococci?
Yeah, you're 100% right. I do feel very uncomfortable giving doxy to a non-purulent cellulitis. I generally don't do that. Again, this is someone I might use Mesalidin, escalate it to that. And depending on the severity or if they're a little older, for example, then, you might say, well, can I use omadacycline? Because the tetracycline that's going to give you reliable streptococcal coverage, other than the roughly 50%, I think it's about a 50% ballpark for what you get with the older generation tetracyclines, metacycline will get you. So have I done that? But, rare occasion. If someone, let's say, is on an SSRI and I can't use linezolid, yeah, you could pull that out of the hat. But yeah, I agree with you. Doxycycline by itself for a non-purulent infection and they have a history of C. diff, particularly then especially if they have a history of C. diff, I might push the omadacycline because of that class effect of being relatively not associated with increasing the risk of C. diff.
Yeah. So George, since we're focused on these patients that potentially can be avoid a hospitalization, or perhaps they have a short observation visit and they're within a point when they need to go home, and we're thinking about these oral agents. What is your preferred agent for someone with a purulent skin and soft tissue infection?
Yeah, if they've been in the hospital and I have the fortune of getting cultures back, then I'm lucky that if they spend couple days in the hospital, then I use the easiest agent. So, purulent, I use doxycycline. Sometimes I might escalate it to minocycline because it's a little bit more active. If someone has had recurrence, I might lean more towards minocycline because the fact that a lot of people aren't aware of, minocycline actually gets very good levels in the anterior nares and the upper respiratory tract mucosa. There was actually a study way back in the early 70s showing that minocycline can actually eradicate meningococcal carriage when back in the day. I think it's from University of Washington. So no one's done colonization eradication with minocycline, but knowing that property of minocycline, if someone has had this is like their second or third recurrence, I might bump from doxy over to minocycline to see if that mucosal penetration might give me that extra benefit, theoretically speaking, without any data, but just having some scientific property of the drug that might help me. So I would say for non-purulent infection, the tetracycline, minocycline. If I've clindamycin might be another one. If it's resistant, we've actually, interestingly enough, we've actually seen a fair number we're seeing, I don't know if you're seeing it, but we're seeing a rise in azithromycin, macrolide susceptibility among our staff. And I've sent actually a couple people home on macrolides with Staph aureus infections because we have, I think, 30% of our Staph aureus is now, which actually includes MRSA, are susceptible to macrolides. So if I'm fortunate to have the antibiogram, I go by the antibiogram. If I don't have the antibiogram, doxymina would be my preferred agents.
So, George, two questions for you. First, tetracycline resistance in staph is rare, more likely to be an MRSA than MSSA, and whether it's TET-K, TET-M driven non-susceptibility to tetracycline. You do see some non-susceptibility, more so to doxy than minnow, but again, we're not looking at it for, much anymore. It's kind of dropped off surveillance programs. But have you ever encountered any staffs that have been tetracycline resistant and you go and test doxy or minnow and you see non-susceptibility to them as well?
It's uncommon when we see a tetra resistant staph. That's another one that I might move away from doxy and use minnow, because every time we've tested tetra resistant isolates, they almost always, I can't remember if we've ever had a minnow resistant one. They always, because a lot of the tetracycline resistance is actually efflux driven, and minnow isn't affected by the efflux. It's only affected by the ribosome methylation. Now, it probably depends a lot on your geography, but in our experience, a tetra-resistant staph doesn't discourage me from using minnow in a soft tissue space.
Yeah, but George, one thing I wanted to ask you, this actually came up, and I'm not sure if you're seeing this as well, is back in late 2009, even 2010, we kind of had that explosion of community-acquired MRSA, and we actually saw more MRSA in the emergency department than sometimes on our hospital wards. But that seemed to have dissipated a bit. Perhaps it's just anecdotal and we're looking at it, but we're seeing less MRSA among patients coming from the community. And we kind of went to the literature to see, is anybody describing this as well? But there's been kind of a dearth of information published over the past few years. I attribute a lot of that to the COVID-19 pandemic. I think there was a shift on priorities. But have you noticed that as well, that you're just seeing a little bit less MRSA among patients with community onset skin and soft tissue infections?
Oh, I think that's 100%. I mean, in terms of, not enough where you can completely forget MRSA, but you still have to consider it in the empiric setting when you're worried about a purulent cellulitis prior to culture, or a phlegmon that's going to turn into an abscess where you don't have culture and you're worried about staph. You still have to address MRSA. Like, I would never give cephalexin alone to a patient with a purulent cellulitis prior to culture, assuming it's going to be MSSA, even though statistically speaking, it's more likely going to be an MSSA. So yeah, we've seen that. I think it's seen nationwide in the U.S. There are pockets where I think it's still high, but there's no question. I think there's been a steady decline in our environment. I think in the U.S. As well. With that said, we were also seeing, even amongst MSSA, like I mentioned, we're seeing more macrolide susceptibility. We're also seeing penicillin susceptibility emerge. I mean, we're seeing PSSAs that, when I was a fellow, you would never think of a PSSA, less than 5 or 2% of isolates. And we looked in our database, and almost a quarter of our MSSAs now are penicillin or beta-lactamase negative. Not that I would ever give penicillin or amoxicillin to a Staph aureus patient, but it is something that's a phenomenon that we're observing among Staph aureus, that we're tending to see less antibiotic resistance. Although I think that comes at a hidden price of virulence that we probably don't have time to discuss today. But I think there's a hidden package that comes with that.
Interesting. So, George, where does Bactrim fit into empiric treatment decisions for you? I mean, the guidelines do make it one of their priority agents if it is indeed a purulent infection that can be managed in the outpatient setting, or someone you can facilitate early discharge. But it seems like that's not one of your preferred agents.
People ask me what my preferred or favorite agent is. I have a hard time, but if someone were to ask me what my least favorite ones, it's this one. It's trimethoprim sulfate. I just don't. I think if you look at the data, the hints are that it doesn't do as well. I think relapses are greater. I think in order to successfully treat a soft tissue infection, you probably need to be giving higher than the double strength twice a day. That might be sufficient for a UTI, but you might have to give double, two double strengths twice a day for a soft tissue. There's issues with tolerances. If the patient is older, you have drug interaction tolerability. I see one or two patients a year with aseptic meningitis due to Bactrim. Every patient that comes to my office with a recurrent infection always seems to be after Bactrim, not another agent. Again, that's a numerator phenomenon. And then finally, I don't know if you know, there was a paper written by Richard Proctor in CID, maybe 10, 15 years ago, he's one of the smartest guys I know in the Staph aureus world. And he raised the possibility that trimethoprim sulfa probably doesn't even work against Staphylococci in vivo because their folate metabolism that trimethoprim sulfa inhibits, there are enough nutrients in the environment that the organism is able to subvert folate acquisition that's blocked by, or folate synthesis that's blocked by trimethoprim sulfa. So he questions whether it actually even works against staph. And it's a nice, elegantly written article, scientific reasoning of why that would be the case. So in other words, I see a lot of negative data for trimethoprim sulfa. I personally never use it other than a UTI space or, again, pneumocystis. But in a soft tissue, you will rarely, if ever, see me prescribe it because of the tolerability and the issues I just discussed.
Yeah, agreed. I mean, a lot of the patients we encounter in our practice tend to be elderly. I mean, the risk of relapse is always on the back of our mind, but they just can't tolerate it.
Right, exactly.
And
Yeah.
the biggest thing is whether it be the high potassium or other electrolyte imbalances, always a concern of crystalluria. A lot of our patients have moderate to severe renal impairment. Just that's their baseline. So it becomes a difficult drug to use. And I'm not sure if you made any of the sessions at ID Week, but there's a couple nice posters describing clinicians' experience with it. And one thing that came across all of them was these very high rates of adverse events.
Yeah, exactly. They can't tolerate it, especially the older. I mean, over 60, you're almost buying yourself an AE for sure.
Yeah. So, George, one thing I would say in the management of skin and soft tissue infections, and in some ways, we are in the golden age of generics, right? We have a lot of viable agents that we can use, whether it's Teflex for non-purulent, and then we have several agents for purulent. I'm a bit more favorable to the tetracyclines there as well. But we do have some new agents that have been brought to market in recent years. I mean, depending on how far you want to go back, I guess we can say linezolid. I think there's more interest in that drug now as a either avoid a hospitalization or transition home now that it's available as generic. We have tedizolid, which is the most recently approved oxysolidone, which doesn't have the serotonin toxicity concern in its packet insert, but does carry some of the other warnings and precautions. And we also have a metacycline, which I think is a welcome addition. We have no concerns about where we're concerned about doxycycline or other tetracycline resistance in the streptococci. Metacycline has very good susceptibility rates and is also a very good MRSA agent. I think that came through in its registrational trials where it was found to be non-inferior to linezolid. So if you could just comment on those few agents, kind of when do what types of patients do you consider some of these newer agents in? Let's kind of work our way down. When would you consider linezolid versus some of the other standard of care agents that you mentioned?
Yeah, so someone who might, where I'm worried about, I'm kind of ambivalent about the staph and strep if it's non-purulent, but I'm still worried about staph maybe, and I really don't want to. I worry about the tetracycline. I might use linezolid. So if I have someone on SSRI, while I feel comfortable giving linezolid, let's say in an ICU setting or in an inpatient setting, if someone has it for other reasons like pneumonia, and I can watch them, I don't take that chance of sending a patient home on linezolid. So I might use omadacycline. If someone has a C. diff risk. Tedizolid is a drug that I think we have used, for suppressive therapy. If I'm worried about, for example, like I have a device and I need to use an oxylinodone, I'll use tedizolid because I think the tolerability of thrombocytopenia and also the SSRI risk is smaller theoretically anyway. So I might use that. So yeah, I think they all have their individual scenarios. I think it's amazing how often patients will dwindle your repertoire of drugs quickly between allergies and drug interactions. Those are some other settings I might use those in. Metacycline when you're worried about C. diff. And then, don't forget also we have the long actings, the injectables, which we can sometimes send people home on. who I might think need IV a little longer, but for whatever reason, we don't want to give them IV in the hospital or through a PICC line. It's either a deep soft tissue infection. We have given that as well, like the dalbavancins, the 1,500 milligrams after discharge.
So George, let me, before we get into the long acting, because I always think about what is the ideal drug, one dose, right? Preferably by mouth, with the long actings get us there. Just to kind of touch upon it. So if, even though tedizolid has a theoretical risk of serotonin toxicity when combined with other serotonergic agents, it didn't show up in the packet insert. They did a lot of it's based on preclinical work, which showed less risk than linezolid. Do you feel comfortable using tedizolid over linezolid if someone's on an SSRI, or would you be more inclined to move to a different drug or drug class?
Yeah, I think that's a good question. I personally do feel comfortable because in order to cause a necessary serotonin syndrome, it actually has to get into the CNS, and tadizolid doesn't get into the CNS, which is it goes with saying, like, if you're treating an infection where someone could have potential CNS toxic, emboli or CNS infection. One situation that comes into mind is like nocardia, where linezolid has been a workhorse over the years because nocardia has a predilection to for CNS, from lung to CNS. We tend to avoid that tadizolid because this doesn't get into the CNS. So I think it doesn't get there. I think that's been documented, and it's really hard to get a serotonin syndrome in an organ system when it doesn't even get into that organ system. So I do feel comfortable. I mean, I have done it maybe. Tadizolid, believe it or not, it's been out almost 10 years now, maybe longer. I've used it a couple of times under that, into that scenario. But and there may be post-marketing experience where that's been described, but I haven't. I do feel relatively comfortable giving tadizolid in someone on an SSRI.
Yeah. So you mentioned omadacycline a few times as a potential agent, as good strep coverage, good staph coverage, limited gram-negative coverage. In some of those situations, perhaps it's a little bit of a chronic wound that gets reinfected, or an infection in the peritoneal area. So at what points do you consider omadacycline as one of your go-to agents? I mean, I anticipate is when you can't use some of the first line agents that you identify, but when do you consider it to use? Who is that patient type?
Yeah, I mean, the first I would start off with is diabetes. I mean, if you look at their diabetic subpopulation, I think they were called Oasis, Oasis One, Oasis Two. I think their trials, when you lump the diabetes groups together, omadacycline actually statistically outperformed linezolid in the diabetic population. Now, hypothesis generating, post hoc analysis, but I mean, it was interesting because it did perform better in diabetic. So in a diabetic patient, I mean, in a perfect world, if the drug were more easily accessible, I mean, I would probably reach for it in a diabetic. And why in a diabetic? I mean, who knows? I mean, maybe there's some neutrophil dysfunction which the linezolid needs to optimally work. Maybe there's other factors, there, but in the diabetic patient, of course, comes to mind, and of course, a C. diff patient, someone who's had C. diff or high risk for C. diff, if they're older, I think that's another patient population that I tend to reach for it relatively early.
Yeah, and there was actually, I'm not sure if you saw it again, it's preclinical animal studies, but they show it inhibits toxin production to a level similar to linezolid, which I always think about as even better than clindamycin in terms of toxin inhibition. So I'm not sure if you came across that,
No,
but I think,
that's another point. Exactly. It's anti-inflammatory.
yeah. So George, a couple things here, given the focus on stewardship, how do we pull this all together, whether it be in a hospital or outpatient clinic? How do we ensure the best drug is used for the patient? And then in situations where we're unable to use, let's say, Keflex for a purulent infection, or it kind of has that kind of mixed picture. You think it's non-purulent, perhaps there's still some concern for Staph aureus, and they want to avoid with tetracycline, with Keflex, or even a tetracycline with Bactrim. And I agree with your reservations about Bactrim. I think there's enough data now to show it is not a good staph drug. How do we integrate stewardship in this to make sure not only that we have a personalized approach for managing our patients with skin and soft tissue infections, but making sure they're getting the right therapy?
Yeah, I think the lowest hanging fruit for stewardship is duration of therapy. I think we way overtreat these things in terms of duration. If you look at the soft tissue trials, I think it's 7 to 14 days or something like that. I think that's, 14 days is way too long for the majority of these patients. I think you can get away with much shorter courses of therapy. So to me, the first, if you bring stewardship with any disease state, soft tissue or anyone, it's duration of therapy. I mean, first. Second of all, there's a lot of patients that get referred to us as quote unquote recurring chronic cellulitis. And you talk to the patient and it's like, well, yeah, it's both legs. And the patient was on salt restricted diet, but he eats potato chips and or frozen foods and canned foods, and it's all lymphedema driven. So being a good doctor and saying, look, this is not cellulitis, even though it's hot and red. This is lymphedema and other hydrostatic effects on the extremities. I think that's another component is don't give antibiotics to people who don't need antibiotics and through good medicine and stop the treatment earlier. If someone is without fever, redness for 48 hours, they can stop the treatment. They don't need to continue that. If that's day 5, they continue to day 7 and they're done. They don't have to continue the next 7 additional days and C. diff has also been associated with duration of therapy. So I think stewardship for me is duration, and it's also avoiding it in people that are sometimes labeled as an infection that don't really have an infection through a couple of detailed questions and the practice of good medicine. Unfortunately, that's easier said than done because now people look at a hot red leg, oh, it's cellulitis, boom, boom, and it's antibiotics, and that's not gonna solve the problem. It's salt restriction and then maybe a diuretic and so on and so forth. So I think to me that's it. But if you're and if but the final point is if you've got a fairly healthy individual, as severe as the infection is, they don't need, even when they come to the hospital, they don't need vancomycin, right? It's still staph and staph, staph and strep, staph and strep. You don't need the gram-negative and anaerobic coverage in someone with an acute infection, even though they're super sick, if they're not comorbid. So stick to staph, stick to strep. Staph, strep, staph, strep. You know, if you're talking about a diabetic foot, a poorly controlled diabetic, someone who's prior antibiotic exposed, yes, open it up to the gram negatives. But if you're talking about a fresh de novo soft tissue infection, almost the vast majority is going to be staph and strep, and stick to staph and strep when you're prescribing your antibiotics.
So, George, two final questions for you. And I'm almost a bit remiss that we didn't discuss this earlier. One of the For a lot of these skin and soft tissue infections, incision and drainage is a must. Assuming you have a good surgical intervention or draining procedure and the infection was of a mild to moderate nature, how long do you, how, when do you not continue antibiotics in those patients? And if you do, how long do you recommend treating?
Yeah, I mean, the true answer is I rarely recommend not giving antibiotics after a sinus drainage. I might give 3, 5 days short course and someone who I'm less worried about. Someone that I am more worried about is the size of this abscess. If this thing was like over 3 or 4 or 5 centimeters in size, obviously that's going to push me over to treating it more aggressively. If someone is immunocompromised, neutropenic, or functionally neutropenic, like a poorly controlled diabetic, another one. Location is also an issue, right? If it's on the face or it's in a very sensitive part of the body, like the perineum, rectum, that kind of thing, I might also be a little bit more worried about, extending duration. So size, location, and host immunity kind of feed into it. But I can't say I've ever recommended, okay, stick a scalpel in it, pack it, and no antibiotics. I think even if you look at population studies, there may not be statistical difference, but there's definitely strong trends towards better results when you give these people antibiotics, regardless of, IND.
Yeah, agreed. I mean, I think there's some trials coming out of the California area that I think demonstrated this well. And even in situations where we probably could just get away with incision and drainage, we're always compelled for a few days of antibiotics. And I guess, George, the one thing is kind of thinking about the spectrum of patients we talked about and still focusing on those and observation, or perhaps they start them on IV antibiotics, at least a dose or two in the emergency department, and the patient, he or she is deemed well enough to go home. How often are you using like the long acting agents like dalbavancin or ridavancin?
Yeah, I mean, we've our hospital a long time ago because those drugs came out a long time ago, well, a few years, maybe 10 years ago, and because of the infusion time of 30 minutes versus 3 hours, I mean, our hospital just made a decision to go with dalbavancin, but oritavancin now has been reformulated. There's an hour long infusion, and so there are reasons to potentially revisit that. But typically have stuck with dalbavancin, and we've used it increasingly more. I mean, there's been more of a push because from not only from the ER, but also getting people home without midlines or PICC lines. And a lot of that is because the post-COVID world has really complicated the third-party payer and disposition situation where it's harder to place patients. So the hospitals are literally filling up with patients for social and logistical reasons. And so in order to make there's any opportunity to free up a bed, the systems have been enthusiastic. Whereas 5 years ago, when this came up, it was kind of like, well, think about it. Now there's been much more enthusiasm to embrace the long acting agents to help streamline. They'll eat the cost of the couple $1,000s of acquisition costs because it'll free up a hospital bed, it'll free up staff, it'll just allow the conveyor belt that's increasingly being gummed up by the what I mean, I don't want to overstate it, but basically the collapse of the healthcare system as it's slowly going on. There's a greater interest and enthusiasm to embrace these long-acting agents more so than in years past.
So, yeah, I mean, the times we have used them, it's more been out of concern for adherence.
Okay.
If we feel that perhaps it could be they're not going to fill their prescription, or they may be one of these patients where they need one of the newer agents and there's concern about prescription coverage, we are more inclined to use it. Does that factor in? I mean, if given a choice, you have someone, you can give them you said dalbavancin, a single dose of dalbavancin, there's high confidence it's only staph or strep, no gram-negative involvement. Or you can give them a prescription for one of the several oral drugs that we mentioned. How do you decide between the two?
Yeah, I think compliance is a key one. I mean, that has been a traditional indication for using the long-acting agents, but also, getting people out in a timely fashion. You might have, like, in situations in the past where you might say, well, we'll keep them here another 48 hours because their white count has gone from 20 to 14. It's still not normal yet. Now, and then we'll send them out an oral. Now we'll say, okay, white count's 14. It's gone from 20 to 14. Let's give them the Dalva. So what we typically will do, we'll give them daptomycin in the hospital and then have them come back to our infusion center the next day. Now the hospital just says, we'll just give them dalbavancin and get them out. I mean, I don't know how it is in your healthcare system, but we really are pressed for staff and beds and utilizing sources in the inpatient setting. So if there's any daylight in getting these patients out, they will use that. They will use the long acting agent.
Yeah, I mean, in our area, George, I mean, we serve all the surrounding veterans, so we have a large, I guess you would call it, catchment area. So sometimes it's just a matter of we consider that, but if the person lives 50 miles away and we have to arrange some sort of car service for them to come the following day, if we have an available oral agent and we have no concerns about compliance, we'll tend to prioritize that. But we haven't fully adopted them yet, but clearly there's increasing use. It's described well in the literature, and we've been thinking about other patient types who require long-term therapy. So that's a podcast for another day. So George, I think we're kind of coming to the end of our time here. As always, enjoyed talking with you. I could talk to you all day about a variety of different topics, but any key, last take home messages for managing patients with skins? I think we gave a relatively comprehensive overview of all the considerations, but any final words?
Yeah, thank you, Tom, for having me. It was great talking to you as well. I would just say to any audience out there, staph and strep, but you don't need broad acting agents unless someone has been on broad spectrum antibiotics or is functionally neutropenic or neutropenic. These cases are almost always staph and strep. So use your decision making accordingly. Purulent to staph, non-purulent to strep. And yeah, and then there sometimes, we have a lot more options than we did in 2014. The guidelines hopefully will be updated with not just microbiology and clinical, but also sort of efficiency in the mind. Because again, these infections, we tend an aspect of this that we didn't talk about too much in the real world is a lot of these patients are young working people, and no one can afford. A lot of these people can't afford to spend 3, 4, 5 days in an inpatient bed getting Vanco Q12 hours over an hour and a half. If you can get these people back working or doing parenting or whatever it is they do, it not only unloads the healthcare system, but it restores them to a quality of life. And I think that's something that sometimes we kind of falls between the cracks in a lot of the decision making. So that would be the only other comment I would make. But again, great talking to you, and I really appreciate the folks who organized this, who invited me and for us to talk today.
All right. Thank you, George. And I also wanted to thank everybody who listened to the podcast today. Thank you for your time and wish all the best.
Yes, thank you, Dr. Lodise and Dr. Sakoulas. To view the full program on acute bacterial skin and skin structure infections, please click the link in the show notes. To get access to all of our podcasts, subscribe to the CCO Infectious Disease podcast on your favorite player. Thank you, and we'll see you on the next podcast soon.